Thanks to Sangeet and AIOC for giving me an opportunity to speak on my favorite topic. So here I'm going to speak on the surgical dimension for the whole retinal vascular disease. That's the topic given to me. So we know that with MIVS coming in, we have now started pushing boundaries, and we have become more and more uh, sort of uh, adventurous in our vitrectomies, and we are seeking more surgical solutions to many of the intractable or incurable disorders that we have got to today. And as we know, any new thing that we try, we get some amount of mixed results in these surgical interventions. Now, most of us, we started the first amount of surgical intervention into vascular occlusions when we started doing a AV sheathotomy for the branch retinal venous occlusions. And the principle was it always occurs at the AV crossing because of the compression of the vein with the artery. And the surgical decompression of the BRVO at the AV crossing was attempted by sheathotomy. Now, unfortunately, the published literature was inconclusive, and then came the anti-VEGFs and the DEX implants. And they started giving better results, and hence it was actually not carried on further. However, we still do use vitrectomy in BRVOs for secondary effect like vitreous hemorrhage, TRD, or we can do an ILM peel for intractable macular edema. Now, coming to CRVO, we know that it always occurs at the lamina cribrosa, and that's where there's a bottleneck of the nerve and the vascular tissue. And the radial optic neurotomy was an attempt to get open of this bottleneck. And it was basically we used to elevate the IOP quite high and go inside with an MPR knife and make a radial cut. Now, the thought of cutting the optic nerve itself was quite traumatic to even think of. And it did give mixed results, but the published literature again was inconclusive. And again, like a BRVO, there came the anti-VEGFs and the DEX implants, which started giving better visual results. And hence, this procedure also took the back seat over a period of time. Of course, like in BRVO, we also use it in case of vitreous hemorrhage, TRD, or ILM peeling for intractable macular edemas. Now, coming to arterial occlusions, unfortunately, other interventions of medical side have not been yet proven to be good. Now, TPA also doesn't really work that much because, as we know, the common cause of the embolus is 74% is cholesterol, and 15.5% is fibrin, and 10.5% is calcific. And hence, most of the times, giving TPA may not be of any benefit in case of a central retinal artery occlusion. And that's why we can think of maybe using vitrectomy as a tool, because by vitrectomy, we can have a prolonged hypotony, we can directly massage the central retinal artery, and we can even do a disc dissection and dislodging of the embolus itself. Now, this dislodges the embolus and establishes the perfusion. Now, there have been a lot of cases that I've seen. Now, this is the one which I like the most. This is thanks to my friend Swamil Seth from Mumbai. This was a one-eyed patient who came with finger counting half feet, and you can see how well the thrombus can be dislodged, the embolus, and you can see it migrating to the periphery. And as you continue with the disc dissection in a hypotenuse eye, you can see the further dislodgement of the embolus. Now, what happens is as your perfusion starts increasing, you can see that the dislodged fragment moves faster through the circulation, which gives us a clue that you're coming to the end of the fragments of the particular embolus that is causing this particular block. So that's sort of a clue for us to know. And of course, the clue is the pulsation of the central retinal artery. Now, there is a group of Japanese workers, or the Yamane group actually, who have also tried to go a step further. And what they have started trying is a 47 gauge microneedle, which is pierced through the central retinal artery to inject TPA. That is just one case that has been told by them, and it has given good results, but we really don't know how to get hold of the 47 gauge needle and to inject TPA, and whether the TPA will be of really of value. Only time will tell, or whether that particular injection is just as a flush to remove the embolus. Now, coming to BRAO, uh, of course, this surgery also works very well in BRAO, like in this case, where you can see there is a disc massage that is being taken place. And after you do a disc massage, the causative blockage, the embolus can be seen being dislodged. Now, this patient went from preoperative, this amount of ischemia, sectoral, to a total, perfusion in this area. You can see the ischemia totally gone. So you can get fantastic results with BRAO also if you do a vitrectomy and you can dislodge the embolus quite well. Now, I have done about 24 eyes and I've got a very good visual improvement in about 30% of these eyes and a moderate visual improvement in 7 eyes. There was no visual improvement in 5 eyes. Maybe the blockage was deep inside the lamina or at the area where the central retinal artery pierces the dura. We really don't know. And the biggest limiting factor in visual recovery is the time at which the patient reports. And most of the times it is more than 3 to 4 days. And then you really can't help them much with the visual improvement. Of course, there are other conditions like angiomas, and we have very adventurous surgeons like Dr. Sangeet Mittal himself, who has done this particular surgery that he's done of angioma being excised after doing a good amount of laser around it and going inside it and then excising the whole tumor, and he's got a fantastic results. But to be sure to tell all the people that this will be tried only by surgeons like Sangeet Mittal who are confident of going an extra mile. Or you can even look at this particular case where there's another adventurous thing attempted by actually suturing the feeder vessel to the angioma in a bimanual way. The suture is passed under the feeder blood vessel and then it is tied off so that you get rid of the blood supply to the angioma. Once you have tied up all the feeder vessels
Sir, your audio is break.
go ahead.
Sir, your audio is break.
So the vitreous surgery for vascular conditions is still evolving. Of course, it is very ambitious in nature. And before going in, we need to weigh the risks versus the benefits. Thank you.